covering the hormones that are secreted by the placenta, produced by the corpus luteum and the placenta. You know that increases progesterone production, so we've covered that pretty well. Progesterone itself, maintaining the uterine lining, quieting the uterus, thickens cervical mucus. Now we're really being redundant. And inhibiting lactation during pregnancy. Thank you. That would just be a lot. Estrogen steadily increases during pregnancy. So look back over this picture. So you see progesterone. Of course, there's more as you go along because the tissue producing it is plentiful. But estrogens increase over time. At one point, you have to have estrogen increase its activity over progesterone's quieting of estrogen because you want uterine contractions at a certain point. So that's going to be the responsibility of estrogen to do that, overwhelming progesterone near term. And will stimulate the oxytocin receptors on the myometrium, and so oxytocin was important for uterus and mammary tissue, and it's one of those positive feedback things, and so you want the stimulus of uterine contraction to grow so that you can have birth happen. Oxytocin itself, produced by fetal cells, as well as hypothalamus, released by the posterior pituitary. So that was one of those made by the hypothalamus, and then it followed the neural tract, and is released from the posterior pituitary. Acts on the placenta, stimulates release of prostacyclins. Uterine contractions can begin. So that's its effect on uterine contractions. Estrogen will have a more direct effect on uterine contractions. Positive feedback, strong rhythmic uterine contractions of labor. And so that's one of the really interesting things, and you know, how far apart are those contractions once they become very organized and proceed. There's a point of no return then where labor will ensue. Speaking of that, okay, that's not even nice. That's not even nice. During labor, the pain is so great that one can almost imagine what it feels like for a man to have a fever. It's just funny. So you do the classes, and they're like, you know, you're this, and it's coming along, and you think you can handle the pain. So you think you can handle the pain. You can handle the pain, and women have had babies for all the millennia without people standing around helping them. And they said, but at a certain point, Mom, you might just kind of forget your mouth, and you say things like, you're never doing that to me again, and everybody just get the F out of the room, and you're like going, and you don't care if you're dressed, and it's kind of true, though, I think. But birth it's terrifying if you think about how terrified someone might be that's pregnant, that's going to give birth. Exciting, they meant to do that, maybe they didn't mean to do that, whatever. But reassurance is just huge. It's painful. Pain is terrifying. Lack of control is terrifying. So when you're in labor and delivery, it's a fun place to be. It's tough. I mean, it's really tough because there are bad outcomes, or there are sad stories. I mean, there are a lot of sad stories and whatever people come in with. But there was this nurse practitioner, or nurse midwife when I was in Tahlequah. And it's just the most amazing thing, and I've done it. I've practiced this, but only with screaming toddlers. There's this level of panic that begins to take over sometimes, and it could be any patient. And I don't know what anyone would think about this, you know, in the administration. but a woman was panicking, and she needed her to stop panicking. And she just went up to her and slapped her hands in front of her face, like she just slapped her own hands in front of that woman's face. And it caught her attention, and she was able to look at her and say, I want you to breathe. And it was such a great technique when somebody was really panicking. Now, I'm not sure that your attorneys at the hospital and the board of administrators would like that, but she didn't slap the patient. She did that in front of the patient's face. And I will tell you, I have done that to a screaming child and just gotten their attention. And they will immediately, you know, you're fine. All is well. But that was so fascinating. And anyway, those midwives deliver, I mean, it was huge numbers of babies. She'd seen everything, and they're not using, for the most part, any kind of pain control with their patients. So they really know how to get their attention and keep them really grounded. So the dilation stage, the cervix effaces and thins. So it opens and it thins. And so I actually never heard this from medicine, but in those pre-birthing classes I went to, the woman said this, and it makes so much sense. So she had like a uterus that was like a sock. Well, it was really just like a sock, and there was a baby in it, but whatever. So this part of the sock that's more elastic up around, so that's like the cervix. So it's the cervix isn't just opening and getting bigger. It's being pulled back. It's opening and thinning, and then pulling back over the baby. So that you know? But that makes so much sense to me. So you have this uterus contracting, and the uterus is literally pulling back over the baby. And that makes a lot of sense for a delivery, I think, in that case, and being projected into the vaginal canal and out. And so when you think about that, that's why uteruses don't rupture very often. You know, that there's this, I don't know, that just makes sense to me mentally, how those contractions are really working, that you're kind of peeling back the uterus away from that infant. So anyway, so the contractions are at the fundus, and then later involve the whole uterus, and then later involve the entire body. So you can feel them all over. And I'll just tell you a little personal story. When I went into labor, I just wasn't going anywhere, and she used a little bit of Pitocin, which is like Oxytocin, to kind of kick it a little bit. And so, and you're watching that monitor, and you really get focused on the monitor. Oh, here's one. Oh, that was a really big one. And you're kind of like going, wow, I think I can handle this. And you're like, and then there's that one, and I was like, and this is it's just to describe so that you can understand what it's like, or you can help someone understand what it's like. But I will just tell you, the contractions started like 2 arrows going into my feet. And I can't describe it any other way except that it started at my feet and came up. It was so big, and so I guess I tell you that simply because you're going to be there at some moment with somebody, and whether you've had a baby or not, but you have to be able to objectify it. You can't get emotionally involved in it and go, oh, I bet that really hurts. You don't do that. Oh, that looks really painful. You don't do that. You're saying it inside like, shit. But as you're standing there, you just really have to go, you have to understand that when she's going, seriously, like, was that one coming from your feet? And then she's like, yeah, you know, so there's just, I want to have a lot of ways of understanding this, because not everyone will give birth, you know, and so, anyway. So there's dilation stage when you're getting there, and then there's the expulsion stage. We're going to expulse the baby now, where it projects out, and that's pretty short time that it gets there. And so contractions last a long time. They're very close to each other. There's an urge to push. and then you have crowning and birth. So anyway, it's so exciting and so remarkable, and I hope you get to experience that as a PA student. And then the placental stage. Oh, maybe that's the one that grossed him out. Doesn't that look big?
Yes.
You don't care a bit, because then there's the baby, and you want to make sure that that is fine, and then they hand it to you, and you just can't like, oh my God, wow, I mean, that was really in there, wasn't it? That's weird. That is so weird. I said to my mother, what if I don't think my baby's cute? And she said, oh, you'll love it either way. I did. So the uterine contractions continue, and then this placenta, that's a remarkable thing as well, that it peels away from the uterine wall. And, you know, again, the uterus doesn't bleed to death very often. Now, that's not to say these things don't happen. You certainly have to look for them, but I mean, of all the pregnancies, these things work out pretty well. The placenta is examined to make sure all the parts are there and none have been retained. And then the uterus will continue to contract for many days, also stimulated by breastfeeding as well, and then bleeding will occur for a few weeks as well. Look at it. Why is that cute, really, when you think about it? It's awful looking. First breath. Oh my God!
So demanding.
Baby!
So demanding.
I had an aunt that said that I loved this, but the obstetrician handed the baby to her and said, "Now your life is forever changed." And that just gives me chills. But boy, is that true? You know. CO2 accumulates, acidosis occurs, and then the respiratory centers kick in, and the first breath occurs. So that's a remarkable thing to go from living completely surrounded in amniotic fluid, not breathing, all oxygen coming from that placenta. And so that's that trick with obstetrics, is that once that process happens, the baby needs to go. And so this is one of your, the big things you're going to try to do is facilitate getting the baby out so that the first breath is air. And so then that's somebody else's deal. If the patient is the neonate, then you get to go take that, and the patient is the OB patient, and you stay there with her, and the baby goes. So anyway, so just to give you an idea of normal breathing rates, breaths per minute, you know, we're around 12. During a test, you're around, 16 or whatever. The baby's newborn, 30 to 60. And so that will cause a new mother a good bit of concern. So when that baby is breathing so fast like that. So anyway, I mentioned these things because it depends on if your patient is the mother. You need to have some understanding about what's going on and why you can help her help educate her. So revision of fetal structures happens really quickly. Umbilical vein constricts and fibrosis. It remains as the ligamentum teres, the round ligament of the liver. Ductus venosus collapses. It becomes a ligament for the liver structure. Foramen ovale, flat. There should be a fossa ovalis remaining. Ductus arteriosus constricts and is just a fibrous connection between the pulmonary artery and aorta. So quickly those things happen. It's unbelievable, really. Umbilical arteries constrict and become part of the artery supplying the bladder. So there's just recycling of all those fetal structures. And if there isn't, then you have something else going on. Lactation, the next big thing in obstetrics from after the baby is born. You want to make sure that, obviously all the uterine on course for normal uterine return. And then the instigation of lactation, prolactin releasing hormones, so these are all redundant from endocrinology, released from the hypothalamus, in response to that elevation of estrogen, high elevation of estrogen, progesterone, and lactogen from the placenta at birth. Suckling physically will stimulate the release of prolactin releasing hormone, and it stimulates the release of prolactin from the anterior pituitary. Targets the mammary glands. This is one of the best pictures. So initiating lactation post-birth. So it takes a couple of days. Initially that fluid is colostrum, and you see it there is the yellow, much less voluminous, very lipid-rich production. And then within a few days you get over into what is really the more typical lactation product. Or milk. I need some lactation product. Hand me that. Smell this lactation product. It's not bad. Anyway, I think that's a really interesting way to see that. High in proteins, vitamin A, sodium chloride, lower amounts of carbohydrates, lipids, and potassium in mature milk. Oxytocin released from the posterior pituitary in response to also stimulation of the nipple, infant suckling. You can even hear a baby and it will instigate that, which is just drats. Targets the uterus for contractions and the alveolar glands for the milk release, so that let down. So, and that's that same picture from last time, and this is just an aside. I'm going to say this. So, breastfeeding is terrific. Do it. By all means, do it. Encourage it. Encourage your partner to do it if they want to do it. But it depends on who that patient is. And so I always say that, because if you're the patient, if the patient is the baby, then you're going to have one perspective, and if the patient is the mother, you're going to have a little bit of another one. But for some reason, and I'm just going to say this does not represent the attitudes of the faculty or OCU generally, but there is this very militant lactation thing out there. I respect very much people who want to promote lactation, but sometimes it's not a fit for a family, and so if your patient is postpartum is very I want to say how can I say it? You want to believe what anyone says to you because you're so lost, especially with that first baby, I think. It's kind of a lot, there's a lot of the hormonal changes going back to normal, and so really there's just the thinking isn't as objective as it might be. And so if somebody is saying you have to breastfeed, and it's not working for you, so often that patient, that OB patient, will think of that as a failure on their part. And so I just would encourage you, if your patient is that woman that is lactating or not wanting to lactate, or lactation isn't going well, she might not want to be honest with you and admit it. So these are these questions like you have to ask. Is that working for you? Because some people bond with it and some people don't bond with it. Some people are good at lactation and it's great with them and their baby, and some people are miserable. And also, it just can be very fatiguing. So I would just say, I personally experienced just this, there was, the Lactation League came to the house because we needed to set up, there was a whole thing. But I went to my obstetrician and I was very ill with mastitis. I had a very high fever. I will just say my milk was pink with blood. And they said, feed it to the baby. Keep feeding it to the baby. And I was so ill, and my obstetrician, gynecologist, I said, and she said, oh my God, I don't know why you didn't give up weeks ago. And I mean, the world opened up by having a provider say that to me. And I don't want this to be just about my experience in lactation, but to tell you that you are going to be in a room with a patient who needs you to be on their side. And so it gives me chills to think of it, but that's what she should have said. She shouldn't have said, no, that baby needs that pink milk. You know? It's like, run on that baby. That baby's going to be fine. You need to be better. And if you're better, the baby will be fine. And so I just think that you might encounter a lot of times where you really need to, you might have someone in the room that wants to speak for the mom, or the husband speaking for the mom. And I'm not even talking about anything abusive, but that you try to really be helpful. I'm like that. I was a terrible person to be in a room with my mom or with my disabled brother, you know? Well, he can't talk, so there's a different thing. But I just mean, you can, you know what I mean? That somebody is speaking for that patient in for a lot of scenarios, and you need to look at that patient, and hear that patient, and treat that patient, you know? And so that's just one of the cases that gives an example of that. But just always be an advocate for your patient's mental health, because their physical health will be better. And babies really do survive on something other than breast milk. Although that's great, that works terrific. So here's what I will say about breast milk. So you have tons of antibodies in it. Certainly a lot of amino acids. It's pre-digested food, basically, so that's a great source of food. You can't give, babies aren't digesting all that well, so it's basically pre-digested. And so when you give the baby the breast milk, it will be bathing its oral nasal tissues in breast milk. But you'll notice that it just, a little bit goes in, a whole lot comes out. But then, you know, you notice a whole lot of other stuff comes out, but whatever. But what it's doing is it will bathe the mucosal membranes in immunoglobulins. So it is, when they say it's great for the baby's immunity, that's true. But the baby doesn't ingest antibody from mother's milk and then have antibodies in their system. Just understand that. So as far as giving the baby antibodies themselves for anti-allergy, and it is true, there's great, you know, less allergy in breastfed babies. But it's really about coating the gut with antibody. Do you see what I'm saying? So it's not all the immunity that baby will have. And so I think there's this real, oh, the baby is just going to turn out to be a serial killer if you don't feed it tons and tons of breast milk. You know, it's just, I just have that voice of reason always helping to get your families through that particular thing, and all the things. Always listen to it. And sometimes just go, maybe you should just smoke again. I don't know, but I mean, sometimes, you know, just you have to go. Don't try to do everything at once, you know, or whatever. So be that advocate for your patient always, always, always. There's a lot of people out there telling them to breastfeed and how to do it best, and man, I hope that works. But you listen to them. So anyway. So here's another little picture of just lactation. You saw it before during endocrinology, but that play of oxytocin and prolactin. Oh. Babies, though. I don't really like babies all that much, but they're so cute in a picture. Pictures of them are often so cute. They don't seem sticky.
You know that baby had to poop like on that stuff at least one time.
Oh, but baby poop is fine. It's just, my mother would say, oh, it's just a little 2-month-old poop. I promise me, it hadn't been in there 2 months, but, you know, but anyway. So that is it. You're done. Are you have a thing at 3 o'clock. So
I'm texting Professor Reggio right now.
how many questions are you going to tell me? How many questions you want so I can tell them? What do you think?
Can't do two things at once.